cost. And another study which says the urine output at first 24 hour is again a independent predictor for the delayed graft function. So if we have a better urine output in first 24 hours, we are less likely to face the issues of the delayed graft function in the patient. So I have initially shown you this photograph where we had a poor perfusion of the graft. So I just want to show what we had done is, just notice this. We have put this kidney on the cradle on the life port system. The initial RI was more than 2 in this graft, but if you see after just 2 hours of perfusion, the RI has come down to less than 1. It was 0.66. So what we want to come out with our study is if the organ is not perfused well, or the studies have also shown that if even in a marginal donors, if we are not sure of the RI of the graft, so we must try and put this graft on the life port system. And if we have if a RI less than 1, then these graft can be used for the renal transplant. What does the literature says for the life port system? There are a number of studies which says even in the living donor renal transplant, the life port system should be used. We must check the RI. If the RI is high, we must wait for RI to settle down before the anastomosis is being done, and we are going to have a better graft function if, even if in a living donor transplant we use a life port system. And this, we know this RI is independent predictor for the delayed graft function, and we, if the RI is low, we are not going to have a perfusion issues in a graft. So ultimately, what we noticed, the advantages of life port system. Yes, it provides us the sealed and sterile environment for the kidney. It's a portable system. It is easy to carry. We can carry in the aircraft cabin also, and it records data in the form of temperature, flow rate, vascular resistance, and pressure, and it keeps on checking again and again, and the data is available from outside the life port system. And it comes with a battery backup, and we need not charge this life port system for 24 hours. Uh, the studies have said in a extended living donors, if we are not sure of the whether the graft will function, we must put these kidney, these are the studies, western studies, where for the extended living donors they have put on the graft on the life port system, and they have checked the RI. If RI is low, they have done the transplant in this patient. They have not wasted this graft, and these graft are being used, and they have noticed that the kidneys have functioned well in these marginal donors also. So what are the, yes, this life port system has few disadvantages. It required training. We should know how to fill up the ice container. There should not be any air gaps. If there are air gaps in the ice container, the desired temperature will not be achieved, and will keep on having the errors before starting the life port system. Another issue with life port system is multiple vessels. If we have multiple vessels, either we can cannulate the large vessel, and we can just perfuse normally the smaller vessel, but we might have a issues with this while if we have a multiple vessels to put this graft on the life port system. Another issue with life port is the cost, because the this life port itself, if we buy one time, it costs around 25 lakhs. That will add on to the initial cost of the renal transplant. So, but what more important is to note the what are the benefits that we will be getting with this life port system. So what is important for us to know, that whether if it is adding value to our graph, that is more important rather than calculating the cost in these patients. The company, I suppose, they have a rental system also, where I think they are charging between 1 to 1.5 lakh per case, where the hospital don't have to. by the lifeboat system. So with consumable, the cost is less than 1.5 lakh that can be added on to each transplant. So what we have concluded in our study, if we exclude our patient who have a cold ischemia time of more than 8 hours, we have a better serum creatinine at 1 month, and EGFR, better serum creatinine at 7 days, and EGFR at 7 days and 1 month of duration. All in all, if we see the patient, if we don't exclude the cold ischemia time, although serum creatinine remains better in the machine perfusion group, it doesn't remain statistically significant. Uh, the 24-hour urine output in these patients where the cold ischemia time was more than 8 hours was much better. It was statistically significant as compared to the patient who had a cold static perfusion. So our study was a limited small group study where the patient who has an extended cold ischemia has shown a better result as compared to the patient where the graft was put on the cold static perfusion. And as of now, what we have seen is a graft function at 6 months. We have a very small number of patients who have reached the 1 year duration. In a months to come, we'll come up with our data at the graft function at 1 year of duration, and at that time we'll be able to tell better in how much the graft function has remained static or improved with the hypothermic machine perfusion group as compared to the cold static perfusion group, especially in a patient who had a cold ischemia of more than 8 hours, or a patient who had perfusion issues while the retrieval is being done. As of now, we haven't used this lifeboat system in a living donors, but we might think of using in a living donors, especially in a marginal donors. We might think of using it in a times to come. Thank you. This is all from my side.
Thank you, Puneet. I'll just take on from here. There are certain questions where, if I see most of the questions. Hello,
हाँ जी sir.
can you hear me?
Yes sir.
Okay, so most of the questions are answered in his talk. So, like he has given the things of what is there and what all things can be. What are the third question which is there? Machine perfusion technology that needs to be addressed to make it more effective or accessible. The major limitation of this lifeboat is the cost. So I just want to inform you all that we are working in close collaboration with DRDO, where they are trying to develop an indigenous lifeboat machine. If they succeed, then the cost will drastically reduce and it will be affordable to all centers. Now I'll request Dr. Sanjay Kolte to take on the rest 4, 5, 6, 7 questions. 1, 2, 3 are already addressed by Puneet, and I have added on to the cost issue. I'll
Yeah,
Good
request.
good,
evening, Sanjay sir. How are you?
yeah, good evening. Good evening, Dr. Shah. Good evening, Dr. Puneet. I must first
Good evening.
congratulate you on a wonderful, very uh, ubiquitously relieving operation by our Indian Army,
Thank you, sir.
redeeming the lost confidence in the entire set of things vis-a-vis our immediate neighbor. And I hope we continue to be equally protective and aggressive in the near future also. With regards to
Yes.
your perfusion, it's been a very informative talk, and it's good to know that we are having a team of doctors who are working with perfusion techniques also. Otherwise, most of us are probably 95% of the teams who perform deceased donor transplant in the country are doing it without perfusion techniques. My
Yes,
question
sir.
to you, before considering the other questions, is what has been your experience with regards to deceased donor transplantation prior to you had these machine perfusion available with you? Do you
Sir,
find any?
we
Yeah.
Sir, actually, we mainly had a delayed graft function in these patients, and we have a reduced urine output in first 24 hours. We usually do have a nil urine output. And with the perfusion, that what we have noticed, main the difference we have noticed is the urine which started coming immediately within first 24 hours, even on table also. In a patient who have a cold ischemia of 10 12 hours, we have seen a on table urine, which is a
Okay.
major difference that we have seen. Then patient recovery is much quicker if the patient is having a urine output in first 24 hours. That is
I,
what the main difference that we have noticed after using this life port system.
oh, that's a wonderful observation. Probably it ensures a hassle-free recovery in most
Yes.
of the patients. That's what we mean. So there's a question which says, what are the current limitations with regard to machine perfusion technology that need to be addressed to? Probably you have mentioned one, that is the added cost of the machine and the added cost to the recipient as well. Any other
Yes.
limitations you would
Sir, it
highlight?
requires little bit of training that we also faced initially, that this machine is very sensitive. So if there is a small air bubble in a tubing, it will show error. So we should
Right.
know how to first to fill the ice, then how to ensure that there is no air bubble in the tubing. Third is to the sealing cannula should snugly fit onto the renal artery or to the aortic patch, because these are the three main things that we should address. We Because this company comes up with the this trials also, they give us training to put renal grafts. The pig kidney or is usually available with them, so we had done a training initially to put the kidneys on this life port system. So with practice, yes, now we are able to do the machine perfusion without any issues.
Okay. Any incidents of machine-related injuries to the
No,
vasculature
sir.
of the
With
kidney?
these sealing cannulas are very safe, sir. We haven't seen any intimal damage is being done. The transport was quite smooth. So yeah, the main advantage that I have also said, the perinephric fat, which usually solidifies one. Initially, that we used to put the kidneys on this steel containers. So with the
Okay.
life port system, it does not happen. We know there are few centers where we are not able to do the benching initially at the retrieval centers. So so we might have to do this benching process at our centers. It become very easy to do benching once the kidney is being taken up from the life port system. With the cold static perfusion, it becomes very difficult to do the benching, because removing the perinephric fat and clearing the hilum is very difficult in these patients. We have seen the injuries actually being done once we did the benching in a cold static perfusion. The injuries have actually come down. The number of injuries have actually come down.
Okay, okay. And the way to decide on the effectivity of the perfusion, probably the time of perfusion that one needs to give to the kidney is, as I understand from your talk, is the reduction in the RI.
Yes,
So,
sir.
does have you compared this measurement of RI on this machine to the actual RI values that we get on Doppler machines? Are they
No, sir.
comparable?
No, sir. You have given a good idea, sir. We'll compare, sir. We'll compare, sir. Now.
Okay, okay.
Yes, sir. We'll
So
compare, sir.
there's a question which says, do you believe that perfusion time should be standardized or individualized based on graft or donor characteristics, the time of perfusion?
No, sir.
So,
The only issue with the timing could be the RI only. If the RI is normal, the bed is being prepared. I don't think there is any point in keeping this kidney for a longer duration on the machine. It will not
okay,
have any. Even the Western literature, even living donors also says only the important factor is RI. So if RI
right.
is normal, it is point 0.4, point 0.5, point 0.6. I think we should remove the kidney and do the transplant.
Okay. So any experience you have had with perfusing DCD kidneys on this machine?
The DCD, no, sir. Actually, we don't have, but we think that in DCDs, it is going to help. We had one retrieval. Actually, it was being done at my center only, Jalandhar, where we had DCD on table actually. So
Okay.
we have removed this kidney. We have placed these both the kidneys on the lifeboat system, but this retrieval was done only a month back. So we are still getting our data. So how the graft actually functions in these patients. Out of these two patients, in one patient the was functioning very well. In one patient, it was not functioning well. So we'll just noting our
Yeah.
data, and we'll come up with the result in a time to come in a
Yes. Yes.
patient where the circulatory death has happened prior to the retrieval.
Because practically we have seen with our experience, limited experience on DCD, is that we have had four patients here, and all
Sure,
four donors actually, and eight recipients. All of them had DGF to begin with,
sure,
although
sure.
seven out of the eight went on to be discharged with a normal creatinine. But
Okay.
definitely there was a period of DGF, and so this would be a great asset to people who are thinking of DCD programs.
Yes, sir. Yes, sir. Definitely it is going to help, sir.
And have you seen this perfusion making any uh, dramatic effect on the kidneys, which were previously considered non-transplantable? Perfusion
No,
making
sir.
them trans.
This was discussed during last IOCT meeting in Goa, sir, where I think a ma'am from South India, she said almost in a marginal or extended donors, disease donors, there was no takers in 30 to 40% of the cases. So
Okay.
almost, if you see, out of 130 kidneys were wasted. So they thought, they haven't checked it on any parameters whether this kidney was functional. And she said they have taken the, someone asked whether you have taken the biopsies from this kidney, so they said no. So a Western literature says yes, in a extended donors we should put these kidneys on lifeboat system. If RI is normal, we must transplant these kidney, we should not waste these kidneys. So
Okay.
our experience is not there on this, but yes, Western literature is there to support the says that in extended donor or marginal donors, we should put the kidney on this lifeboat system and then do the transplant.
Okay. You have mentioned about multiplicity of vessels.
Sure.
Is one more question about that is, in case of multiple vessels, would you bench and make a single vessel out of them before perfusing, or would you
Sir,
like to?
sir, good idea. We haven't tried this, but it's a good idea, sir. We'll do it now, sir. It's a good idea,
Okay.
sir. Whosoever has
Okay.
given it's a good idea, sir.
Right. And what specific intraoperative techniques have you have proven most effective in reducing DGF rates in high risk kidneys? Intraoperative techniques to prevent DGF after probably machine perfusion? That's one of the questions.
Nothing, sir. Nothing different that we do, sir. Only to ensure that perfusion is adequate, sir. That is the only thing we generally do. It's a standard practice, sir. There's nothing
Placing
different
them.
that we. Yes, sir.
Okay. Placing them on larger vessels, probably the
Yes,
common
sir.
iliac
Yeah.
or that's
Ji,
what you
sir. That
want.
is the general practice that we do, sir. It's a standard. Nothing different that we do in these patients, sir.
Okay. And how do you adjust your surgical approach based on the donor type, DCD, DBD, or ECD? That's the
Nothing, sir.
last
We are generally
question.
doing internal iliac and internal iliac artery and vein, sir. That is the standard that we are doing in our center, sir. So nothing
Okay.
different that we are doing as far as a living or diseased donor is concerned, sir. We
Okay.
are only doing internal iliac, sir, at R&R, sir.
So there's been a great interaction, Dr. Puneet.
Sir,
It's
thank you, sir.
definitely very revealing information. And I'm sure if, as you say, the DRDO helps out in reducing the cost of these machines, we can market them probably to the entire country, and that will definitely increase our disease donation rates also and the results also. Thank you so much for being with us.
Thank you,
And
sir. Thank you for chairing the session, sir.
yeah, back to you, Saurabh. You can take the concluding remarks.
Thank you, sir.
Yeah.
Any concluding remarks, Amit, sir?
No, I think the discussion was very nice. Sanjay sir has clarified a lot of doubts and his experience. I think it's all fine. Thank you from my side.
Thank you, sir. So, on behalf of Indian Society of Organ Transplant, we would like to thank Amit sir and Puneet sir for his presentation and enlightening us on prevention of delayed graft function. And next ISOT EduConnect, we will meet again next month. Thank you, everyone.
Thank you, everyone. Thank you, Dr. Saurabh. Thank you, Dr. Sanjay. Thank you.
Thank you. Thank you. Good night.
Good night, sir.
Good night.